So he has clearly laid out the foundation for how volume distribution occurs. So my topic for the day is about hyponatremia. So I'm not going to get into the nitty-gritty of the pathophysiology of hyponatremia, but rather I would settle to give you some algorithms as to how to manage hyponatremia. As diabetologists, most of us would be kind of familiar with what we call as the translocational hyponatremia, where when you have very severe hyperglycemia, for every 100 milligram per deciliter of glucose, it attracts water into the intravascular compartment, it dilutes the sodium, and therefore you have to make a correction. So for every 100 milligram per deciliter of sodium of glucose increase, you have a approximately 1 to 1.2 milliequivalent drop in serum sodium. So this correction has to be made before we actually proceed to call it as hyponatremia in the settings of hyperglycemia. But now I will stick to a common algorithm which I would use. So I would illustrate it with some clinical cases. So let's take the case of a 55-year-old male with cirrhosis due to alcohol. He presents to the endoscopy department and for a transplant workup and is found to have an asymptomatic serum sodium of 128. His serum osmolality is 260 and his urine osmolality is 450 and urine sodium is 80. He is not on any diuretics. What could be the cause of this hyponatremia? Is it because of volume depletion? Is it because of excessive consumption of beer? Or is it because of SADH? Or is it true volume depletion? So this is a very common problem, especially in cirrhotics. When you look at it, low serum sodium. Your question is to know what is the mechanism that is driving the serum sodium. So I will share a small algorithm. This is the algorithm which I use. There are several algorithms which are available when comparing to when you're managing hyponatremia, but this is a simple algorithm that I use in practice. All you have to do is first check the serum osmolality, and if the serum osmolality is low, you call it as hypoosmolar hyponatremia. If the serum osmolality is normal or elevated, you call it as pseudo hyponatremia or hyperglycemia, where you have translocational hyponatremia. Then the next step is to look at the urine osmolality. If you find the urine osmolality is less than 100, then the water diluting capacity of the body is retained. Therefore, you have a dilute urine, and therefore your urine osmolality is low. So this kind of situation happens only when when you see in compulsive water drinkers and people who consume a lot of beer, where they drink more water. Beer is just water, 0 calories, and a little bit of solute. So beer photomania and primary polydipsia are good examples of a situation where urine osmolarity is very low in the face of hyponatremia. If you find the urine osmolality is greater than 100, it implies that anti-diuretic hormone is acting. Vasopressin is acting. Therefore, the body is able to retain free water, and therefore the osmolality of the urine appropriately rises. But in the setting of hypotonic hyponatremia or hypoosmolar hyponatremia, you want to get rid of additional osmoles in the urine. But if ADH is acting in that kind of a scenario, it is inappropriate, and therefore we call it as inappropriate secretion of antidiuretic hormone. So if you check the urine sodium, if the urine sodium is less than 20, it is volume depletion. If it is greater than 40, then it is SADH. Now let us apply to our given situation. So this patient with cirrhosis, he has a urine osmolality, he has a serum osmolality of 260, which is hypoosmolar or hyponatremia. In other words, it is not pseudohyponatremia or translocational hyponatremia. And if you look at his urine osmolality, it is 450, which means that ADH is acting. So urine sodium, when you check in this patient, it is greater than 40, which is about 80 milliequivalents. And therefore, this is a clear-cut case of SADH or hypothyroidism or cortisolism. Therefore, if you look at the TSH and cortisol, and if you actually negative, then now let's take the case 2. It's a 24 years old male who's an alcoholic. He presents to the emergency department with a blood pressure of 120/80, and he appears euvolemic. His serum sodium is 128, osmolarity is 265, urine osmolarity is 60, and urine sodium is 10. What could be the cause of this hyponatremia in this patient? Now let's apply the algorithm here. So the algorithm here is serum osmolarity. Excuse me.
Has gone into the previous algorithm.
Yeah, the serum osmolality in this case of this patient with the second case is again, it is low. It is around 260. So it's an hypoosmolar hyponatremia. However, his urine osmolality is less than not. It is less than 100. It is not high, which means it is excreting free water. But if you look at his urine sodium, it is not less than 20. I mean, it's less than 20, which is which means he's retaining water. So there is aggressive water retention and also appropriate ADH action in this particular patient. Therefore, this patient is, if you look back at the case again, is serum osmolality is low, his urine osmolality is less than 100, his serum sodium is less than 10. So he is excreting a very dilute urine and he is retaining his sodium. Therefore, this is not a case of SADH, but it's a case of beer potomania. Now, low urine sodium due to very dilute urine is a classic example of excessive consumption of water, but intact water excretion. Case 3. Now, here is a patient who is coming, who is an 89-year-old male. He falls in the curb coming out from watching a show, brought directly to the emergency and noted to have an impaction type fracture, femur. He's a heavy smoker with COPD. His serum sodium is 123, serum osmolality 260, urine osmolality is 290. Urine sodium is 73. What is the cause of the hyponatremia in this patient? If you go by our algorithm, if the urine osmolality is greater than 100 and if the urine sodium is greater than 40, then it is consistent with SADH. This is what we see in this case. Sorry. Therefore, this patient is a non-smoker. His fall and fracture femur is only incidental. And he is also having COPD. But through the sodium, you can make a diagnosis of SADH. And if you make a diagnosis of SADH, the commonest cause for SADH is a squamous cell carcinoma or a small cell carcinoma of the lung. Being a smoker, that is the diagnosis for that particular patient. Okay. Now, having given that small algorithm, all you have to remember is low serum osmolality, greater than 100 serum urine osmolality, greater than 40 urine sodium. If you have that, then you make a diagnosis of SADH, which is the commonest diagnosis. The rest is relatively easy. Once you exclude SADH, the rest is relatively easy. Now, there's an entity called mild chronic ambulatory hyponatremia. Now, this is a common problem which most of us would encounter these days, because when you get an elderly patient and you do a electrolyte panel, most of the time you will find a serum sodium of 125, 126 or 128, and you're not sure what to do with this. These are otherwise ambulatory patients without any kind of symptoms. But this particular study tells you that ambulatory hyponatremia is not very benign. Hyponatremia increases the risk for mortality, it increases the risk for falls, and increases the risk for fractures, as I demonstrated in the third patient. Now, if you ask a patient who has got mild hyponatremia, when you interview him in a one-to-one basis in the OPD, even if the sodium is 128, you will not be able to make a diagnosis very clearly unless you ask them to do certain cognitive tests. For example, the number connection test or connecting individual numbers together as you do it in the case of an hepatic encephalopathy. I've given you examples of live cases from my own patients where they have drawn the number connection test with serum sodium as low as 125 or 128 or 129. Even at that level, their ability to connect the number connections were not very normal. Therefore, sodium of 128 or 129 or 130 is never benign unless you actually do a proper cognitive examination of these patients. So, when it comes to treating serum sodium deficit, I would leave you with this simple formula. Pardon me, I'm not relatively well, but I'm trying to kind of, give you a few nuggets of this whole information so that the kind of presentation is not too long as well. Pardon, kindly bear with my shortened presentation. So whenever you want to correct sodium, the key question is how you want to correct your sodium. So the current consensus across the states now, hyponatremia is an extremely, especially the treatment of hyponatremia is an extremely contested issue across the Atlantic. And you find Europeans having a different approach, the Americans having a different approach. And now I've given you a YMED approach as to go about this particular problem. If any hyponatremia that is more than 48 hours is called chronic hyponatremia. Any hyponatremia, the duration of which you are not sure of, should be considered as chronic hyponatremia. And your rapidity of correction of this hyponatremia must follow certain rules. You don't want to correct more than 4 milliequivalents in the first 4 to 6 hours and not more than 10 to 12 milliequivalents in the next 24 hours. That's very important for us to follow. Now, how do you want to go about it? Irrespective of whatever be the sodium level that you're going to start your correction from, I would request you to follow the following principles. You can calculate your total body sodium deficit, and then you can go about correcting it using different formulae. But the formulae are not very perfect. The formulae assume certain ideal conditions, which I'm not going to get into in detail. But you have to understand that there is no substitute for repeated testing of sodium when you're correcting sodium. So if you want to make a correction, let's say, for example, I want to get a target sodium of 144 from a sodium of 140. My difference in target sodium to serum sodium is about 4 milliequivalents. So I want to raise it by 4 milliequivalents. In a 60 kg female with a serum sodium of 150, if you want to raise the sodium by 4 milliequivalents in 4 hours and 10 milliequivalents in 24 hours, your correction is about, when you apply the formula, it's 50% of the total body weight into 4, which is about 120 milliequivalents, which will be given by 240 ml of 1 liter of 3% saline. So it's about 520, 512 milliequivalents. So therefore, you can give it at 60 ml. You can easily calculate it as 60 ml per hour. So in the next 20 hours, after the initial 4 hours, you can calculate it as 180 milliequivalents. You want to give another additional 6 milliequivalents. So applying the same formula, target sodium minus serum sodium into lean body weight into 0.5, which is if it's a female, it's 0.5. If it's a male, it's about 0.6. If you use this correction formula, you can readily obtain your rate of correction for the total 24 hours. So a shortcut for this method when you're using 3% saline for a 24-hour correction is 0.5 into body weight in kg in ml per hour. Therefore, if you have a female which is about 50 kg and you want to correct it, it's 0.5 into 50, which is about 25 ml per hour over a period of 24 hours, and you will reach 10 milliequivalent correction over a period of 24 hours. This is a rough rule of thumb, and which will not be valid unless you correct it every 4th hourly or 6th hourly. You check your serum sodium. So therefore, this rule applies only to administration of salt without water, not normal saline alone. Only estimate and serial measurements are needed. It does not account for ongoing losses or isoosmotic losses. I'm not going to get into it in very complex situations where you have somebody who has undergone a gastrointestinal surgery or a Whipple's procedure on a Ryle's tube and has got an active drain, has got a urinary catheter, is profusely sweating in a non-temperature controlled environment. In all these kind of situations, the amount of sodium loss will be much higher. But the formula will be sufficient to start with. Therefore, it's about body weight in kg into 0.5 into 0.6. But whatever you're getting, you correct it as ml per hour over a period of 24 hours with frequent monitoring or frequent checking. So let's illustrate this with another case. A 30-year-old female, she has severe diarrhea for 5 to 6 days and presents to the ER with hypotension and on a lab serum sodium of 150 with no neurological symptoms. She receives about 5 liters of normal saline, and 6 hours later, her serum sodium is 125 and is putting out copious amounts of dilute urine. So, in 6 hours, you have raised the serum sodium to about 10 milliequivalents by giving just plain normal saline about 5 liters. Now, what would be your next step? You want to stop the IV fluid, you want to monitor for clinically any neurological symptom, or you want to give 5% dextrose with DDAVP, or you want to monitor labs and only intervene after she reaches serum sodium of 130. Now, this question is important. As I said before, you don't want to correct sodium very rapidly, especially when you're not sure of the duration of hyponatremia. Therefore, You don't want to correct more than 10 milliequivalents or 10 to 12 milliequivalents in a matter of 24 hours. But here, in this case, within a matter of 6 hours, this patient has risen our serum sodium to about 10 milliequivalents. Therefore, your appropriate action here is to reduce the rapidity of rise of serum sodium, and you want to give her 5% dextrose, and you want to give her a DDVAP to blunt the rate of rise of the serum sodium. A 70-year-old male with lung cancer, he presents in the clinic with asymptomatic serum sodium of 125, osmolality of 260, a urine osmolality of 900, and urinary sodium of 150. What is the diagnosis here? The diagnosis here is very clear. It's SADH. Because if you apply the earlier algorithm which I told you, if the urine osmolality is more than 100 and urine sodium is greater than 40, it is consistent with SADH or hypocortisolism or hypothyroidism. When you exclude hypocortisolism and hypothyroidism by the appropriate test, including the normal kidney function, if you exclude all the three, what is left out is SADH. So this is a case of SADH. But here, look at it. The value of urine osmolality is about 900 and the serum osmolality is about 260. So here, mere fluid restriction, will it help, is the question. So to illustrate this point, I'm giving you a simple explanation. Kindly bear with me. This is very important for us to understand. The normal solute intake per day is about 600 milliosmoles. And this 600 milliosmoles is excreted in our urine in 1 liter or 2 liter or 3 liter, depending upon the amount of water that you're going to consume. So let's take the case here. If somebody takes 600 milliosmoles and his water intake is about 2 liters and he excretes about 3 liters of urine, his urine osmolality will be 200 ml. So 3 liters of urine, 600 milliosmoles. 600 milliosmoles divided by 3 liters will give you 200 osmolality in the urine. So his negative balance is about a liter. So which means that if you restrict the serum, if you restrict the fluid to 1 liter in this patient who is normally consuming 2 liters, he will put out 1.5 liters of urine and excrete 400 milliosmoles, and he will be a negative balance by 0.5 liters, and the serum sodium will start rising. So the basic idea in management of SADH is you want to promote free water excretion in these patients, free water or electrolyte-free water. So if you have mere fluid restriction, alone will not help in any situation where the urine osmolality is greater than 400. So I'm not going into the rest of the detail in great detail, but I'm just giving you a rough rule of thumb. When you are diagnosing a case of SADH, if your urine osmolality is more than 400, mere fluid restriction will not help these patients. You have to give them furosemide, or you have to restrict the fluid, and you also have to give them a V2 receptor antagonist like tolvaptan in order to increase more electrolyte-free water losses in these kind of patients. So if urine osmolality is greater than 400 to 600, then you will have to give furosemide to lower the serum osmolality of these patients. A few words about V2 receptor antagonists. One of the things which I commonly see in practice is a lot of patients are put on tolvaptan for every hyponatremia which people encounter. This is not right. V2 receptor antagonists are particularly useful in only two situations: hypervolemic hyponatremia as in cardiac failure or liver failure. Especially in liver failure, when you are going to give V2 receptor antagonists, you're going to be extremely careful about the drug because it's hepatotoxic. But in hypervolemic hyponatremia, as in cardiac failure, it is particularly useful. But euvolemic hyponatremia, it is a drug of choice. But rampant use of V2 receptor antagonists in all hyponatremias without knowing the mechanism of this hyponatremia, whether it is hypervolemic or hypovolemic or euvolemic hyponatremia, leads to a lot of problems. One, it can lead to rapid correction of hyponatremia and then can result in the ODA, or oncotic demyelination syndrome. But it's important that long-term hyponatremias, and without defining the mechanism of hyponatremia, we should never ever attempt to control the hyponatremia just by giving them tolvaptan. Tolvaptan is not a simple drug. Tolvaptan is extraordinarily a dangerous medication. It can precipitate hepatotoxicity. It can precipitate ODS long term. Cannot be diagnosed immediately. ODS takes weeks or months sometimes to manifest, and therefore it's important for you to follow up these patients for long term. So the rampant use of tolvaptan as a drug of choice in managing hypernatremia should not be encouraged, and people have to be very careful in using these agents. Many hyponatremias can be managed by fluid restriction, can be managed by giving furosemide, especially the urine sodium is greater than 100, identifying the underlying cause for SIDA. For example, if it's a lung cancer, treat the lung cancer, the hyponatremia will naturally resolve. If it is cardiac failure, manage the cardiac failure, naturally the hyponatremia will resolve. If it is liver failure, and unless it is a liver failure with advanced MELD score, which will never improve without a liver transplant, it can be still managed with management with fluid correction, fluid restriction, and appropriate use of furosemide. Don't use tolvaptan for all patients without any event. I mean, it has got long-term consequence. For example, this is one of the premier trials which was used in the study of tolvaptan, called the SALT trial. If you look at it, if 10 patients in each SADH arm had a very rapid correction. 8 out of them had a rapid correction, 8 of them reaching more than 8 milliequivalents in 8 hours. And the overcorrection was about 6% in this with the first dose of the drug itself. And subsequent doses, the rate of correction was 7%. So it implies that when you use tolvaptan, there is always scope for a very rapid correction of hyponatremia, which is very dangerous, which we have to be very careful. So in real life, when you are going to use tolvaptan, you have to be very careful because the efficacy of this agent is particularly very high. And therefore, you have to start with the smallest dose possible. So don't give 15 milligram as a start dose. You can start with 3.75, 3.5, then go to 7, 7.5, 3.25, 7.5, then 15, and titrate the dose accordingly. But unfortunately, what is available in the market is only 15 milligram, and majority of the people tend to give 15 milligram, forget about it. But I've seen many cases of patients who have got subtle paraparesis or quadriparesis, especially they had been given tolvaptan for without defining the mechanism just to correct the hyponatremia. Never do that. So I'm not going to go into great detail. So therefore, I will stop short of it. Kindly pardon me. I'm not well, though I kind of go through the. I wanted to go through the pathophysiological mechanisms, etc. But unfortunately, I just left you with some inputs in terms of management of hyponatremia, and I've given you my algorithm. Hope that this will be useful to you all.
Thank you, sir. Thank you
Thanks a
for your
lot.
excellent